All right, so my name is Dr. Dianne Narine. I'm a general surgeon currently working in the transplant department. Um, our team is quite a small team for our country. I hail from Guyana, which is located in South America, but it's also considered part of the Caribbean. We're part of Commonwealth, of course. So I just want to talk to you today about a little bit of our recent peer exchange that we had. This was actually a little bit late last year. So chronic kidney disease, as we know, is a global health burden and very prevalent from country to country. In WHO, these are some 2020 statistics that showed that the deaths in Guyana actually reached about 233 or 3.2% of the total deaths, which for our population, which is about 800,000, is actually quite a large number. Kidney transplantation, however, is a treatment of choice for these patients with end-stage renal disease. And of course, there's some benefits over dialysis for all age groups. As of September 2024, these are statistics from the US. There are about 90,000 patients in the US actually awaiting kidney. In our country, we only currently do kidney transplants. We're unable at this point in time to do liver and pancreas, but of course, there are many patients still awaiting liver and pancreas donations from other countries. And because of this waiting list, even with deceased donor programs, there are still a number of patients that are still awaiting kidney transplants. Unfortunately, in our country, we don't have a deceased program right now, so all of our donors are actually living donors. And sorry, so we've like because of that, we've also been falling behind in terms of donors. So there's a lot of education that's still needed to push forward kidney transplants in terms of living donors. There are two main strategies that have been developed to overcome these barriers. So desensitization versus paired kidney donation. And this is basically the exchange of kidneys between two or more ABO or HLA incompatible donor recipient pairs. A little bit of the history, basically it was started in 1985, all up until 1990. The first paired kidney donation was actually done in South Korea, and then further done in Europe, and then until the 2000s actually started in the US, and then it's made its way further down around different countries. Guyana, we actually started our first peer exchange in 2018. So far, we've done four. And of course, uh, it tackles certain issues that we may have with certain patients in terms of incompatibility in transplants. Of course, it increases transplant opportunities for these patients, and some patients are actually able to get a better match out of being in a paired exchange. When do we actually consider it, or when do a lot of people actually consider it? It's all transplant candidates basically with a living donor who is medically able, but they cannot donate to that person. Or if they do, if they are even able to receive a kidney for that patient, but if they're able to receive a better match transplant would be consideration for peer donation. Outcomes, they've had two studies, which I actually came across in some of them more recent in 2017, that actually showed that the KPD transplant versus person-to-person transplant had the comparable, basically 1 year and 3 year graft survival rates. And these were two studies basically taken out of Canada and another one from the National Kidney Registry. So what has been our experience with KPD so far? So in Guyana, we have a number of patients suffering diabetes and hypertension. Those are two main chronic diseases that actually factor into chronic kidney disease. Our number of transplants per year is actually increasing. We have, even though it's a small program, so we've done last year, we actually completed about 15 transplants for the year. We've completed 4 peer donation from 2018 to 2025. And last year, we actually did our chain transplant with 4 donors and 4 recipients. So how is it actually done here? We actually don't have like a national registry of patients for donations or recipients. These are patients that come to our clinic basically with that have been referred from nephrology, and we have a list of those patients that once they have a potential donor, they're asked basically if they're willing to participate in a paired exchange in the event, for example, that we are able to find a patient or they're incompatible in some way. These pairs are done consecutively due to our limited staff and room availability. And the post-ops are closely monitored in our unit that is prepared. So This was actually our chain transplant that we were able to complete. This is between last year, October to November. This is the largest period exchange that we were able to do in the country. And so these were the four donors and the four recipients. Actually, one of the one of the recipients was actually the very first transplant patient that our program had done about 10 years ago. And he actually started back on peritoneal dialysis about 2 years after. And he actually completed his second transplant in this same chain transplant that we had. One of the patients was preemptive, and two of the patients were already on dialysis. One patient was on dialysis for approximately about 6 months, while the female patient was actually on dialysis for about 2 years and awaiting a kidney. That female patient actually brought her son for donation, and unfortunately, because of incompatibility, he was unable to donate to her, and then they were able to take part in our chain transplant. So our challenges still remain with donor shortages because limited availability, because we don't have a deceased donor program, so we still rely on living donors. Um, and public awareness and resources for us also remain one of the challenges that we also have. So we're constantly trying to educate patients in terms of they always believe that, okay, they can only bring a relative for donation, or they're not even sure about how transplant works. So we're constantly trying to get the health sector to actually take this up so they can actually educate patients further on transplant. Other challenges we actually have are their need for a formal registry and our lab resources. Currently, we are unable to do cross-match locally, so all of our samples are sent overseas for testing. And in some cases, if we don't have a match, we would actually have to ask them to do a virtual cross-match for us so we can actually go ahead if we do think that there's a potential for us to take part in a peer exchange for any patient. This is actually a picture of our team during our chain transplant. We have a long vision basically for kidney health, and we would like to have a comprehensive renal care system with advanced transplant options. Hopefully, we can implement our disease donor program, and of course, implementing our education and policy frameworks for this as well. So in conclusion, peer transplant is a promising method to enhance renal availability. We need a successful implementation and requires some collaboration among medical professionals. And it has the potential to significantly improve patient outcomes, especially in our facility where we still rely on living donors. This was a picture of our team. Currently, this was in our PACU, actually, post-transplant of the last recipient that we had. So that is it for me. Do we have any questions?